So there is no disclosure. The only disclosure here is, and that's for the Americans, is that we are not very often faced with this kind of problem here for two reasons. One is primary arthritis of the hip is uncommon in India. And the second reason is that we don't fuse the spine that much. So we don't really need to split hairs so much about it. At the same time, we do need to know the theory. And let's look at our perspective. So the issue really, I think there are two issues from the hip surgeon's perspective. One of them is dislocations and how the stiff spine affects the dislocation rate. And the other issue is what comes first. Does the hip come first or the spine comes first, other things being equal? And I think that to understand that issue, we just need to look here. And what's important is that if you do a lumbar fusion and a THR, if both of them are together, your hip dislocations hugely increase. And I don't think hip surgeons would really want that, because that's a catastrophic failure as opposed to somebody who gets pain after a lumbar fusion, because that can always be managed. And the problem is worse with multiple fusions. So when there is no fusion, your hip is safe. 1 to 2 level fusion, it's a problem. But with multi-level fusions, your hips are really at risk of dislocating. And it's something you really don't want. So it's the same thing. Even if you fuse the spine later, you can have a problem with the hip dislocation. And you wouldn't want your patient going off for a spine surgery later and then coming back with a hip dislocation. And for that, the spine surgeon needs to be aware of how to fix that. Now, as spine surgeons, we are more concerned with the proximal junctional kyphosis. And that's why we look at the sagittal alignments, as was spoken by Dr. Iyer in the morning. And that's how we dial in our lordosis. But as spine surgeons, we need to be aware that we would also be affecting the hips. And that, again, is where the problem is. So the question is this, the first and the most important question would be what comes first, the hip or the fusion in a patient who's equal. So obviously if you have a patient who has got a neurological deficit, you're not going to treat the hips. And if the patient has got a tremendously painful hip, you're not going to treat the spine. But all things being equal, patient needing both, what would you do first? And this is really the crux. The crux of the matter is this, that what happens? That the spine and the pelvis, they are not different patients. When the patient comes to you, we look above the pelvis, and when the patient comes to you, you look below the pelvis, but it's actually the same patient, right? So we are treating that patient. And the issue here is how the pelvis moves between sitting and standing. So that is the crux of the matter. And the important point is that for the pelvis to move, the spine has to move as well. So when the spine helps the pelvis to move, that is when your hip moves. So it is a shared responsibility between the hip and the spine, and if the spine is not moving, then the whole responsibility goes only on the hip, and that is where the problem of dislocation occurs, between the sitting and the standing. And then the problem arises as to if the spine is stiff, is it stiff in lordosis, or is it stiff in a straight back? Because as the word has been coined, are they stuck standing or stuck sitting? And conversely, there are different dislocations which you may get, either anterior or posterior, depending on how the spine is. So this is what a normal thing would look like, that between sitting and standing, you can very clearly see that your hip is flexing, but your lumbar spine is flexing as well. And you would well understand, if that lumbar spine is not flexing, you are in trouble. So this is really the problem. So the pelvis in standing antewards and the acetabulum retrowards and vice versa. And there are these complex measurements which are there, but the important thing truly is the sacral slope. I think when you understand all of this, there are only two things you need to understand. One, the pelvic incidence or the PI is fixed. You cannot change it. And the second thing is the sacral slope is what is important for your movement of the pelvis. So if you have something like this, which is a rigid balanced spine, so he has got his lumbar lordosis well in place, and his spine is rigid balanced. In standing, he's fine, but when he sits, there is this anterior impingement. And a repeated anterior impingement, correct me if I'm wrong, would cause loosening or a dislocation at that point. And if, on the other hand, if he has a rigid unbalanced spine, that is a spine which is fixed in kyphosis, then in sitting he's okay, but when he stands, there is going to be a problem. and you look at a posterior impingement and an anterior dislocation. So therefore, if you, so that was one part of the question. The second is which first, and as we've clearly said, that the dislocation rates are higher if the hip is done later. And there are two reasons for that. I think one of the things is that maybe you can't get the position right, but the most important thing is the fact of the soft tissues helping to stabilize your hip. And again, I'm not a hip surgeon, but I'm assuming that the soft tissues would stabilize over a period of time, and therefore, if you do the hip first and do the spinal fusion a lot later, your hips are safer. And there is a huge paper written on this based on the Medicare database, where they've clearly said that you should do the hip first, and that's what's paying for my lunch, I'm assuming. Of course, if you look at this paper, it says that you should do the spine fusion 5 years later, which may be too long, but the point is that it's better to do the hip first and the spine later. So, as I said, I'm not sure whether this is a major problem in India because we don't do that much of spine fusions, and the hip replacements too are done mainly for other indications rather than primary osteoarthritis. But for the spine surgeon, if I was giving this talk to the spine surgery community, I would say that, listen, be respectful of your hip surgery colleagues. If the patient already has a hip replacement, please fuse in the correct order. Otherwise, the hip will dislocate, and then, you can blame the hip surgeon, but the hip surgeon knows in his heart that the hip is dislocated because you've not fixed the spine well. And the other thing is delay the spine fusion a bit. My topic was spine fusion after bilateral THR. And as I said, the spine surgeons usually are more concerned with overall spinal balance. So we are more concerned about proximal junctional kyphosis and what the spine X-ray looks like. And we would tend to dial in the lordosis based on the pelvic incidence. So high pelvic incidence, more lordosis, low pelvic incidence, less lordosis, because we are concerned about the spine and the junctional kyphosis. But we do, as spine surgeons, need to be aware that this will impact the hips. And if this patient has hip replacements done in the past, we need to be aware of how the hip is placed, how the cup is placed, and maybe speak to the hip surgeons and then have the lordosis accordingly. And as far as the literature is concerned, a longer interval is better to prevent dislocations. So don't let somebody do a hip replacement and do your spine surgery within 3 months, or even worse, try to do it all together, because you're putting the hips at risk while your spine will be safe. Thank you very much.